Today we are going to discuss some image-based questions which have become an important part of your examination these days. So let us begin. The first question I want you to answer is: a patient presents with dull ache in the leg which worsens at night. X-ray shows the following picture and the likely diagnosis has been asked. Now, in this question, there is a hint. There is a dull ache in leg which worsens at night. So this points towards one diagnosis which is known as osteoid osteoma, because in cases of osteoid osteoma, there is a dull aching pain which worsens at night. Now, if you see on this X-ray, there is involvement of the diaphysis of the bone, again pointing towards the osteoid osteoma. Furthermore, there is a presence of a nidus which is surrounded by sclerotic bone, and in between there is a radiolucent area, and this is known as a nidus, and this is one of the characteristic features of osteoid osteoma. So our diagnosis in this scenario is confirmed, and the best answer here is the osteoid osteoma. Coming on to the next question. In this question, the examiner asks the following X-ray can be seen in which of the following situations. Now, if you see here, this is the X-ray of most likely the hand, showing the phalanges, and here you can see that there is a pestle in a mortar kind of appearance. Now, pestle in a mortar kind of appearance is characteristically seen in cases of psoriatic arthritis. So, psoriatic arthritis happens to be the best answer for this question. Next, the examiner wants you to tell which test is this and when can a positive test be seen when you do this. Now, this, as you know, is a Tillandenberg test. Now, Tillandenberg test is basically done to see the strength and integrity of the abductor mechanism. If you see in this rough diagram here, I have tried to make the hip joint, and this hip joint is basically being stabilized by the abductors of the hip joint, which are gluteus medius and gluteus minimus. The nerve supplied to gluteus medius and minimus happens to be the superior gluteal nerve. Now, what happens is when the person tries to stand on one leg, and the other leg is raised off the floor, the pelvis remains square, that is, the pelvis does not droop on one side, and this is the normal mechanism which is helped by the abductors of the hip joint. Now, the abductors of the hip joint try to stabilize the pelvis and keep it straight and do not let it droop on the other side even when the patient does not bear weight on that limb. So this is known as the Tillandenberg test negative, which means that the pelvis remains square even when the patient stands on one leg. However, if in the same scenario, when the patient stands on one leg and the other leg is raised off the floor, if the pelvis droops onto the affected side, that means that the abductor mechanism is impaired somewhere. Now, the abductor mechanism can be involved either due to one, the defect in liver arm, the liver arm of the abductor mechanism being the femoral head, the femoral neck up to the greater trochanter. So this is the liver arm of the abductor mechanism. The fulcrum, which happens to be the hip joint, or the force vector, which in this case happens to be the abductor muscles of the hip joint. Now, if there is a defect in any one of these, then this Tillandenberg test can be positive. For example, if the gluteus medii or minimi, if any of these muscles are not acting properly, say in cases of a superior gluteal nerve injury, then this will lead to a weakness of the abductor mechanism and in turn a positive Tillandenberg test. Likewise, if the liver arm is compromised or shortened, for example, say in cases of Perthes disease or in cases of say septic sequelae, the abductor liver arm, that is the length of the femoral head and neck, may be shortened as compared to a normal limb, and in these scenarios the Trendelenburg test will be positive. Likewise, if there is a defect in the fulcrum itself, which happens to be the hip joint, in that case also the Trendelenburg test will be positive, and these can be seen in cases where the hip joint can be involved, such as in cases of a rheumatoid arthritis patient or ankylosing spondylitis patient, or in cases where there is avascular necrosis of the hip joint leading to arthritis of the hip. So, Trendelenburg test depends upon the integrity of the abductor mechanism, which involves the fulcrum, which is the hip joint, the liver arm, which is the femoral head and neck, and the abductor muscles, which are the force vectors. If all of these are intact, only then the Trendelenburg test will be negative and the pelvis will remain square even when the patient lifts one leg off the floor. If any of these fulcrum, liver arm, or the force vector is affected, then the pelvis will droop onto the affected side, and that is known as a positive Trendelenburg test. So in this next question, the examiner asks you, the following clinico-radiological picture can be seen in which of the following scenarios? Now the options given are Mafuji syndrome, Ollier syndrome, von Recklinghausen syndrome, or none of the above. Now if you look at this picture carefully, you will see that there are angiomas over the patient's wrist joint. Now angiomas are basically fluid, blood-filled cavities, and there are multiple angiomas in this case. Also, what you see here is that there are deformities of the fingers. When you look at the X-ray picture here, what you can see is there is involvement of the flat bones, and there is calcification inside it. Now the tumors which involve the flat bones are usually enchondromas, and we all know that enchondromas, when they are multiple associated with angiomas, usually the diagnosis happens to be Mafuji syndrome. So the answer is Mafuji syndrome. Now, one or two things which you need to remember about this syndrome is that around 25 to 30% of enchondromas in this syndrome are pre-malignant, that is they have malignant potential, that is they can turn into malignancies, while in case of an isolated enchondroma, this incidence happens to be less than 1%. So in an isolated enchondroma, the malignant transformation is less than 1%, while in a case of Mafuji syndrome, this is 25 to 30%. Also, in Ollier's syndrome, there are multiple enchondromas, but there are no angiomas. So Ollier's syndrome is basically multiple enchondromatosis, while Mafuji is a combination of angiomas and multiple enchondromas. So there are some named tests which need to be remembered, and this image-based question is based on that test. In this scenario, what happens is that the patient keeps his thumb in between the palm and the examiner forcefully ulnar flexes this arm at the wrist joint, and that can lead to tenderness, and this test is known as the Finkelstein test. And this test is positive in cases of a dequervans tenosynovitis. So this test is basically the Finkelstein test, and it is painful and tenderness is elicited in cases of dequervans tenosynovitis. Coming on to the next question, here it is asked, the following presentation on CT scan can be seen in which of the following conditions? Now, if you see carefully here, the vertebral body shows something like this. This is known as the corduroy appearance, and this is one of the characteristic features of hemangiomas of the spine. Now, hemangiomas of the spine can also represent something which is known as a polka dot appearance, which we can see here. This is like a polka dot, so this is known as a polka dot appearance. So this presentation is seen in hemangiomas, but they can also be seen in hemangioblastomas and even in lymphoblastomas of the spine. But if this question is asked and if hemangioma is one of the options, go for hemangioma. Now the next question asked is identify the following brace. Now this brace is known as the Taylor's brace, and Taylor's brace is used for supporting the spine in disease pathologies such as tuberculosis of the spine, spinal fractures, and other disease pathologies which involve the spine starting from D4 to L2 vertebral level. So basically the Taylor's brace is used to support the spine in various pathologies, and it is used best for pathologies from D4 to L2 vertebral levels. If we have to support lower lumbar vertebrae, then something known as a Gold-Thwart brace is a better option than a Taylor's brace. Coming on to the next question, here it is asked, the most likely diagnosis in this case is. Now, if you can see this image, there is adduction of the forefoot, and at the ankle joint there is inversion, and these features are seen in CTEV, that is congenital talipes equinovarus deformity. Now CPT is congenital pseudoarthrosis of tibia, but its clinical presentation is very different from that of a CTEV. Cerebral palsy can have varied presentations, but it is usually associated with spasticity of lower limbs and hemiplegias or quadriplegias, but this kind of presentation is not there in a case of cerebral palsy. Now DDH is developmental dysplasia of hip, and that involves the hip joint. So this scenario, the best answer is CTEV. Now here the examiner asks you that this traction system is used to manage which disease condition, and if you can see here, this is a child of probably around 1 to 2 years of age, and this traction system is known as gallows traction, which is used to manage the femoral shaft fractures in children. So this is a gallows traction, and the management, it is used in the management of femoral shaft fractures of children up to 2 years of age. Now this question is very interesting because every word in this matters, as every word changes the diagnosis of this question. Here the examiner asks you that an infant presents with fever and raised ESR without any local signs of inflammation. Which of the following, with the following X-ray, and the most likely diagnosis has been asked. Now the first thing is, it is a case of an infant. The second thing is that the patient presents with fever and a raised ESR count. Now if you can see in this X-ray, what you see is periosteal reaction at multiple places. Now periosteal reactions which involve multiple bones can be seen in cases of infections and can be seen in cases of scurvy also in children. They can also be seen in cases of Caffey's disease, which is infantile cortical hyperostosis. Now fever can be seen in cases of infection. Fever can also be seen in cases of infantile cortical hyperostosis. Raised ESR counts can be seen in infection. Raised ESR count can be seen in Caffey's disease also. However, what differentiates the two is this line which says that there are no local signs of inflammation. Now, if there are no local signs of inflammation, that means that the likelihood of a CRMO or multifocal osteomyelitis is unlikely in this scenario because there are no local signs of inflammation. So we are left with the best option, which happens to be Caffey's disease, because in infantile hyperostosis, the patient can present with tenderness at the side, the patient can present with fever, the patient can present with raised ESR count, but there are no local signs of inflammation. So the best answer in this scenario is Caffey's disease. Well, thank you friends for listening. I hope you enjoyed the session. Goodbye.